clinical presentation and the mechanism of symptoms that will lead to the obvious clinical presentation, diagnostic evaluation. Then we'll start the classification, the primary benign tumors and the primary malignant, and lastly, the secondary tumors. So neoplasm of the heart can be divided into primary cardiac tumors arising in the heart and secondary from distal metastasis. The primary cardiac tumor can be further stratified into benign and malignant. And the incidence of the primary cardiac neoplasm range from 0.017 to 0.09 or 0.019 in unselected autopsy series. We can see with this classification, the primary benign tumors is accounting for 75%. 50% is myxomatous. 20% is rhabdomyoma, fibroma, and papillary fibroelastoma and lipoma. And the rest of 25% is primary malignant, which is angiosarcoma, rhabdomyosarcoma, leiomyoma, and lymphoma. We'll talk about then the secondary cardiac neoplasm. So this is a diagram showing the various percentage of the benign and malignant tumors. You can see the highest one with the benign is the myxoma, and with the malignant is the angiosarcoma. This is a classification based on the pathology.
This distribution is mainly for the left atrium. When you look at the distribution between the left atrium and the right atrium, you will see that it's true that in the left atrium, the majority of tumors are benign, 75% to 25% roughly. But when you look at the right atrium, the distribution is almost 50-50, 50% malignant tumors and 50%.
Yes, exactly.
Benign. Okay.
This is based on the pathology. So the tumor, mural thrombi, and tumor of the mesenchymal tissue, and tumor neoplasm of the fat, like lipomatous hypertrophy on interstitial septums, which is classified into lipoma and liposarcoma. We can go through that. This is the percentage from Lawrence of the benign cardiac neoplasm. The myxoma is about 50% with lipoma, and the third one is papillary fibroelastoma. The clinical manifestation can be divided for a general mechanics categories. We have 4 categories that will invent the clinical manifestation. First one is the systemic manifestation, embolic manifestation, and cardiac manifestation, and phenomena secondary to metastatic disease. And we'll go each one by one. Regarding the systemic manifestation, it's almost constitutional symptoms of fever, chills, fatigue, malaise, and weight loss, in addition to myalgia and arthralgia. And you can see in routine labs the elevated WBCs and ESR, anemia, thrombocytosis, or thrombocytopenia. And the systemic manifestation are believed to be produced by secretory product released by the tumor or by the tumor necrosis, mostly in the cardiac myxoma, which is caused by increase in serum interleukin-6. The second one for the mechanism is the embolic phenomena or embolic manifestation. Systemic or pulmonary embolism by tumor emboli or thromboemboli formed on the surface of the tumor. The propensity to embolize depends on the origin of the tumor, either intramural or intracavitary, and the friability of the tumor surface, which is most commonly seen in cardiac myxoma, mainly the villus surface. And the brain is the most common site for emboli, which can cause the TIA or ischemic stroke, but rarely intracranial hemorrhage. Coronary arterial embolism can can be seen and can mimic the MI features. BE also rare and most common with the right side. Cardiac manifestation, direct mechanical interference with myocardium or valvular function, or can interrupt the coronary blood flow or the electrophysiological conduction or accumulation of pericardial fluid, like in some tumors we call cardiac tamponade. For the left atrial tumors, intracavitary lesions that are pedunculated and mobile can interfere with mitral valve, which can produce features of mitral regurg. And physical examination may reveal sign of pulmonary congestion with an S3 and loud and wide split S1 with a hollow systolic murmur, most prominent at the apex, which is radiated to the axilla. And the diastolic murmur form a turbulent blood flow through the mitral orifice and tumor blob. The tumor blob, which was showing on the echo and ultrafast CT, show the tumor obstruction in the mitral orifice with a Bisson-like action. It means that the first pushing of the bolus of blood into the ventricle and then coming to rest in the mitral orifice. This sudden bolus of blood plus the tumor in the ventricle cause a third heart sound called tumor blob, while relieving the left atrium of that volume and cause an abruptly descent in the left atrial pressure. The last one of the cardiac manifestation is the metastasis. Truly, metastases are by definition features of malignant primary cardiac tumor. Common site is the lung and the brain, bone, liver, and lymph nodes. So this is regarding the clinical manifestation and mechanism. Concerning the diagnostic approach, the clinical exam, chest radiography, ECGs, echo, CT, and MRI. This is a differential diagnosis for each chamber. You can see in the left atrium, 24 of the masses or the distribution of pathological characteristic of cardiac mass, 24 is myxoma, 6% is thrombus, and 3% is sarcoma. Regarding the right side or right atrium, can be thyroid cancer or inflammatory or pseudotumor. Myxoma is 5%, thrombus is 2% for the right atrium, and melanoma is 1%. So the first primary benign tumor is myxoma, which is comprised 50% of all benign cardiac tumors in adults and 15% in the children. The vast majority of the myxoma are sporadic and tend to be more common in women, with a peak incidence at third and sixth decade, with 94% are solitary. 5% of them are showing familial pattern of tumor development based on autosomal dominant inheritance, like in Carney syndrome. The pathology for the myxoma, both biatrial and multicentric myxoma are more common in familial and are probably arise from bidirectional growth of the tumor originated from the atrial septum. And generally arise, at the border of the fossa ovalis, but can originate anywhere within the atrium, including the appendage. In addition, the isolated report confirmed that myxoma can raise from the cardiac valves or the pulmonary artery and veins and vena cava. The right atrial myxoma are more commonly to be broad-based attachment, and they are also most likely to be calcified, which is helpful to be seen in the chest X-ray. Right ventricular tumor typically arises from free wall, and left ventricular tumor to be originated from the posterior papillary muscle, proximally. Grossly, about 2/3 of the myxoma are round or oval tumor with a smooth or lobulated surface, and polyvoid, compact, pedunculated, mobile, and not likely to be fragment spontaneously. Less commonly is the villa style, or papillary myxoma are gelatinous and fragile, which is prone to fragmentation and emboli. The average size is 5 centimeter in diameter, but growth 15 centimeter, and as large has been reported. Histologically, composed of polygonal shaped cell and capillary channels within the acid mucopolysaccharide. And the cells appear to be singular or small cluster throughout the matrix, and mitosis are rare. For the clinical presentation, as we mentioned, this is the classic presentation for myxoma, the intracardiac obstruction with congestive heart failure, which is account for 67%. Sign of embolization is about 29%. Constitutional symptoms, 19%, weight loss or fatigue. Immunological manifestation, myalgia and weakness, and arthralgia, 5%. Cardiac arrhythmia, disturbance and infection can occur, but is less frequently. Regarding the clinical exam or the diagnostic approach for the myxoma, the finding at the time of clinical assessment vary according to the size and location and mobility of the tumor. For the left atrial myxoma that cause partial obstruction of the left ventricle, or the left ventricle may result in elevated pulmonary vascular pressure with augmentation of pulmonary component of the second heart sound. Chest X-ray, the finding may be cardiomegaly, dilated chambers, pulmonary congestion. ECG is non-specific, can show bundle branch block and axis deviation. 20% can be presented with atrial fibrillation. Echocardiography, which is the best information can be provided by TEE, which can provide the tumor size, location, and mobility. And the sensitivity of echo for myxoma is 100%. Coronary angio performed in patient who is more than 40 to rule out other significant coronary disease. So this is an echocardiography which shows a large left atrial myxoma. CT and MRI is the most useful in malignant tumor because its ability to demonstrate and delineate the myocardial invasion and tumor involvement. MRI can employ in the diagnosis and may yield a clear picture about tumor size and shape and the characteristic of the surface. And the MRI, which is particularly useful in detecting intracardiac and pericardial extension and invasion of the malignant secondary tumors. Both CT and MRI can detect as small as 0.5 to 1 centimeter and provide information regarding the composition of tumor. But neither CT or MRI need for atrial myxoma if adequate echocardiogram is available. The exception is the occasional right atrial myxoma that extend into one or both cable or tricuspid orifice. Management, surgical resection is the only effective therapeutic option for patients with cardiac myxoma and should not be delayed because of death from obstruction to flow within the heart or embolization, which can occur at 8% of patients awaiting for the operation. Minimizing or handling the heart to avoid the fragmentation of the tumors. Approach is median sternotomy inside the pericardium away from the midline to have, apart from the pericardium if you wanted to harvest this as a batch for repair of the large defect. Insert a mitral retractor hitching up of the right pericardium only. Aorto-bicaval cannulation with snaring to prevent any leak. Surgery is performed with antegrade quadriplegia arrest at 32 degrees centigrade. Then thoracotomy is dictated by location of the tumor, which is usually attached to the left side of the interatrial septum. Approach via an oblique right atriotomy, then incision the floor of the right atrium in an transseptal approach. The tumor is most commonly attached by stalk, which is broad-based, to the atrial septum. This should be excised with 5 millimeter margin full thickness. Then a sterile dessert spoon is useful to help to evacuate the friable or gelatinous tumor. After that, repairing of the small septal defect, less than 1 to 2 centimeter, with double layered 4O running proline, and large defect with pericardial or dacron badge. The airing of the left atrium and the closure of the atrium in 2 layers or 1 layer by matrix suture. Removal of the atrial myxoma carry an operative mortality of 5% or less. The mortality is related usually to the advanced age and the other comorbidities. Recurrence of non-familial sporadic myxoma is about 1 to 4%. So this is a large left atrial myxoma before going to the second type, which is the cardiac fibroma, which is the second most common primary cardiac tumor in infant and children. 90% in children less than 1. And there is no sex predilection. Majority appear to be non-familial. Clinically, patient can present with heart failure, arrhythmia, syncope, and presenting finding are the presenting finding, while less common presentation include sudden death and atypical chest pain. 1/3 of the patients of cardiac fibroma remain asymptomatic, and ECG might show an evidence of left ventricular hypertrophy, right ventricular hypertrophy, bundle branch block, AV block, and VTACs. Chest X-ray also is not specific. I mean, it will reveal only cardiomegaly with or without focal bulge and calcification. Echocardiogram the fibroma appear as a homogeneous echogenicity lesion. So perioperative assessment with CT and MRI are more desirable for evaluating the lesion, which can delineate the heterogeneity of the neural mass and the degree of calcification. The differential features favoring fibroma over rhabdomyoma is the calcification, which is occur more in fibroma, and the complete resection in symptomatic cases is recommended. Lipoma and lipomatous hypertrophy of the atrial septums. So the benign lipomatous tumor can be divided into 2 major primary based on the degree of encapsulation, either lipoma or lipomatous hypertrophy of the atrial septum. It can be sporadic with equal occurrence on both gender. Mostly were asymptomatic, and typically were an incidental finding. Can occur at any atrial or ventricular surface, most commonly in subepicardial and subendocardial location, although intramyocardial lesions have been reported. For the subendocardial lipoma, with a prominent intracavitary component, can result in symptoms of heart failure. Whereas the subepicardial tumor, which is usually asymptomatic, but large lesion may cause compromise to the heart and produce pericardial effusion. It can go to tamponade. Intramyocardial lipoma can cause a rhythm or electrical conduction abnormality and arrhythmia. TEE followed by CT is the modality of choice, as they display a low attenuation signal similar to subcutaneous or mediastinal fat. Size typically from 1 to 8 in diameter, and treatment of cardiac lipoma is surgical resection. Lipomatous hypertrophy of the atrial septum are massive fatty deposition of the atrial septum, and it is non-capsulated, with excessive accumulation of fat in the atrial septum at the level of the fossa valves, that is more than 2 centimeters in thickness, typically in elderly and obese patients, and at the mean age of diagnosis is 70. Clinically, does not cause any symptom and can result in rhythm disturbance and even sudden cardiac death due to fatty tissue infiltration to the atrial myocyte. In rare instance in which the tumor protrude into the right atrium and SVC, patient will present with symptom related to blood flow obstruction. CT and MRI are the most desirable as they are superior to echo in differentiating the fat from the other connective tissues. Atrial septum is thickened up to 7%, where normal less than 1, but this thickening always avoids the fossa ovalis, giving the atrial septums a dumbbell or hourglass shape. So this is a dumbbell or hourglass shape of the tumor. And surgical management should be restricted to hemodynamically compromised patients. Papillary tumors of the heart valve are the third most common primary cardiac tumor, which is 0.3, clinically mostly asymptomatic, and show 50% having TIA, stroke, or angina, myocardial infarction, and dyspnea. Cerebral emboli symptom present in more than 50% in symptomatic patients. TEE is recommended, or the modality for diagnosis, generally appear as round oval irregular lesion. 80 to 90% are found on valvular endocardium, mostly the aortic valve. 44% have a 1 to 2, 3 stalk, and it is mobile, and appear to be more likely to give rise to embolism. The treatment of papillary fibroelastoma is surgical excision of the tumor or shaving from the valvular leaflet with either reconstruction or less commonly replacement of the valve. The primary malignant tumor, which is 4 or 25% are malignant of the benign cardiac tumor, most commonly are sarcoma, followed by lymphomas. Metastases accounting for 20 to 40%, more common than primary benign tumors, and mostly to the lung and breast. Hodgkin and non-Hodgkin lymphoma, malignant melanoma, and primary gastrointestinal neoplasm, and various other types arising from extra cardiac location can also a secondary involve the heart. The more common malignant tumors are angiosarcoma, leiomyosarcoma, rhabdomyosarcoma, malignant fibrous histiocytoma, and undifferentiated sarcoma, fibrosarcoma, and malignant lymphomas. So this is the percentage. The angiosarcoma is the accounting for 33%, and rhabdomyosarcoma, mesothelioma, and lymphoma. Sarcoma showing a high mitotic activity, more than 5, to high power field, extensive tumor necrosis, and poor cell differentiating, which will lead eventually to poor prognosis. CT and MRI, large heterogeneous broad-based mass that frequently occupy the most of the affected cardiac chamber. MRI is the method of choice of the sarcoma, which is show the evidence of extension into the cardiac chamber and pericardium. So the first type is the angiosarcoma, most common type, can occur between 30 to 50 years in adult. Slight male pre-declension exists and can occur sporadically and present with advanced age with 60%, typically already demonstrate an evidence of metastasis at initial presentation. Initial finding, chest pain, constitutional symptoms, dyspnea, and evidence of heart failure. Pericardial effusion and tamponade can present or can be a presentation. Hemorrhagic pericardial effusion or tamponade usually indicate the tumor infiltration into the myocardium. ECG of non-specific ST changes, arrhythmia, AV block, and non-specific features with the chest X-ray like cardiomegaly, inhaler lymphadenopathy, and pleural effusion. TEE is the modality of choice. CT and MRI for better characterization of the tumor growth and involvement, and appear as low attenuation, invasive, irregular nodular mass showing a heterogeneous enhancement. This is on CT. On MRI, it shows an heterogeneous mass with the frequent pericardial involvement and hemorrhagic pericardial effusion. A multidisciplinary approach to the treatment of the cardiac sarcoma is advocated, including combination of surgical, irradiation, adjuvant or neoadjuvant, and immunotherapy with interleukin-12. So here is the chemotherapy, surgery for complete resection. Neoadjuvant may be administered to reduce or to downstage the tumor size. And this is the chemotherapy types. It is an aggressive neoplasm with a poor prognosis with a mean survival of 9 to 10 months. Leiomyosarcoma, malignant mesenchymal tumor with histological and immunophenotypic evidence of smooth muscle differentiation. It can occur in the fourth decade, and there is no apparent sex reduction. The common clinical presentation: dyspnea and chest pain, pericardial effusion, arrhythmia, and heart failure. Up to 80% can arise from the left atrium, and they tend to extend into the pulmonary trunk. Echo followed by CT or MRI for diagnosis. It's a rapidly growing tumor with a high rate of local recurrence and distant metastasis. The same thing, poor prognosis with a mean survival of 6 months. Lymphoma account to 1.3 to 2% of all primary cardiac tumors, commonly associated with HIV, post-transplanted lymphoproliferative disorder, and Epstein-Barr virus. The average age is 60 to 70 with a male predominance. Clinical picture of or presentation of chest pain and heart failure with pericardial effusion. ECG of non-specific, echo followed by CT and MRI. Right side involvement more common, size 3 to 12 with mean age of 7. Treatment, early implementation of anthracycline-based chemotherapy with or without radiational therapy, which is the mainstay of primary cardiac lymphoma. The secondary cardiac tumors, which is incident up to 14%, and from in the cancer patient, and up to 3 points in general population. Cardiac metastasis can either by direct extension, by bloodstream or lymphatic. And pericardial metastasis up to 70% is the most common, followed by epicardium, then myocardium, and 5% endocardial metastasis. So this table showing the type of the malignancy, like leukemia, and the percentage of the metastasis. As we said, the pericardium is the most often involved because of direct invasion by thoracic cancer, including breast and lung cancer. Abdomen and pelvic may reach the right atrium through the IVC. And the most exhibiting tumor is renal cell cancer. The clinical manifestation of secondary cardiac tumor, the most common symptom is pericardial effusion or tamponade, heart failure, arrhythmia, acute MI, heart block can be there. ECG, ST changes, which can mimic the myocardial injury, neo AFib or flutter, and low voltage. The surgical therapy is limited to relieve the recurrence of pericardial effusion and occasionally the tamponade, which is accomplished by a subxiphoidal pericardiotomy with reliable relief of the symptoms and recurrence rate. Alternatively, is large pericardial window through the left pleura, creating using a thoracoscopy. So this is about the cardiac neoplasm. Mainly, I focus on the myxoma. Thank you so much. And then if you have any question.
Thank you, Dr. Hassan.
يعطيك العافية.
الله يعافيك.
حسن بس ممكن أسأل سؤال؟
تفضل.
When we are removing the myxoma from the atrium, we are usually removing part from the atrial septum, right?
Okay.
So in case of the ventricular myxoma, do you think we should remove the part from the free wall of the right ventricle, or chafing, or removing part of the papillary muscle on the left side?
You mean in the left ventricle?
Yes, or just removing the myxoma, it's enough. ما أدري دكتور فريد إيش رأيك؟
Well, I have asked one of the surgeon here, National Guard. They said according to the location, if it is attached, you have to remove part of the septum. You have to remove it, then you will repair it. But I didn't go through that.
هو
ايوه مرتضى ايش كنت حتقول؟
كنت بقول إن what I know that removing the whole myxoma is important to reduce the recurrence rate, but actually I don't know what's the answer, and we should weigh the recurrence rate with how much myocardium we can resect. I think it will be individualized because of course there's a maximum extent of resection that we can do. Yes.
So when you look at the pathology, most of the myxomas are pedunculated. They have a stalk. They have the stalk is the attachment to the endothelial part of the septum. It does not of the septum or the wall of the free wall, whatever. So in the pathology, it usually does not penetrate to the other side. It's very superficial. Still with that, in the atrial wall, we try to resect full thickness. And the main reason is that to avoid recurrence. The reason we'd like to avoid recurrence is that it becomes very poor prognosis if the patient come back with recurrence. He probably will not be curable, and most likely he will die as a complication of his disease. Yes, it is slow growing tumor, but we should aim for complete removal. And actually, many times we send the specimen to the pathologist, asking specifically for if we manage to get the whole tumor or not. There are also remote possibility of having this familial type, which is multicentric. So you may have more than one site. I've never seen this, but if you see it, it's a bad prognosis, and you should try to remove as much as possible. Now with that, of course, you would try to avoid, because of the multicentricity, the likelihood that this patient will have recurrence and will come back again is there. Is there a medical treatment for this? If I remember correctly, there is a medication that they use to suppress the recurrence rate in the familial type. Coming back again to the specific question that if you have this attached to a papillary muscle, yes, I would remove the papillary muscle, which means that this valve most likely will need to be replaced, the mitral valve. If it's attached to the free wall, the attachment area is usually very small, and you can resect that as a button. We do that routinely with many other issues with the heart. So you can remove a small button of about 1 centimeter or so and repair that directly. How far does the myxoma invade into the myocardium? It rarely does. So if you decided that, well, I'm going to only shave half of it, but the thing is, to reach that area, for example, if it was close to the apex, you still have to open the apex, and you may still have a problem of trying just to shave a small area from it. I'm not sure, I haven't seen it, but at the same time, I feel it's easier to remove the stock with bulk of the muscle, complete excision of the wall, full thickness. Thank you.
Dr. Farid, when you said direct repair of the ventricle, you mean just simple sutures with a pledget, or you will put patch?
I usually repair the ventricle with only sutures. If the area was involved with ischemia, or if there's an aneurysm formation, then I feel that the tissues may not hold very well, or it may expand later on as the fibrous tissue does not have is not resilient as the muscle, so it will balloon, and if it balloons, it will rupture. So in those cases, I use the pledgets. The way I do it, if it's large enough, I use 2 strips. I use it as a pledget, run the sutures from the top to the bottom with some interrupted sutures in between.
Thank you.
Can I ask you a question for the presenter?
Yes.
There is another entity I didn't hear you talking about it, which is the rhabdomyomas. Did you speak about that?
No.
It's a benign tumor. It's very bulky, very huge, but it has very peculiar thing in its prognosis. Does any of the senior know that?
Rhabdomyoma, it's the most common tumor in pediatric age group, and
Okay.
usually or most commonly occur in both ventricle, right and left ventricles. And the prognosis is, it's benign tumor, but the prognosis is not that good. Usually discovered at late stage when there is bulky tumors, and when you resect that tumor, there is no much remnant of the ventricle. So the treatment is palliative.
Okay. So the thing they talk about in this particular disease, if you can make the patient survive, like he has no major obstruction or dysfunction, this tumor will disappear. It will resolve itself. So the message here is not to operate on them unless if you have to. And the main reason you will have to is if they develop significant obstruction. So let's say you have a very bulky tumor that involves the lateral wall, the septum, and obstructing the flow to the LVOT. The surgery for this is not to resect as much as possible from the tumor, because if you do so, you're going to remove quite a bit of the ventricular wall that will not recover. The patient may not come off bypass. And even if he does, he will have heart failure down the line. The message for this patient, the advice is to go in and just relieve the obstruction, the left ventricular outflow obstruction. If the patient survived for a year or 2 with that, most of these tumors will resolve on its own. I think some people have made a mistake, including in our institute, where they went after the tumor as much as possible, and they ended up with dead patients. So again, the message is to leave those tumors if the patient is asymptomatic, because those will resolve on their own. حتى لو كان كبير يعني ومل الدنيا بس ارجع سبحان الله يختفي. Of course, the most important disease to know in the cardiac tumors is the myxoma, and you have to know the details of it. There's some I think there are some chemical tests that you do, and there's also some medication that can be used. The familial type is the worst one, and the total resection is the advice. The other tumor that you have to think about is metastatic tumor, and those are very poor prognosis. Usually the patient end up dying within a few months with tamponade or severe dysfunction or valvular disease, or from the original metastatic tumor. Thank you, Hassan.
Okay, if there is no more questions or comments, I think we shall proceed to the next presentation.